Dr. Kumar has a long oops with the oops moments.
So some of flap complications I'm just going to quickly show. Can I have the audio? So we're going to go fast because this session has to finish by 2:20. So first one is patient comes next day. This was a normal microkeratome.
Flap noticed a few hours after surgery. The flap is everted. 2 dry sponges should be used to iron out the folds on the back surface of the flap.
So this was immediately after surgery, then you don't need to worry.
The use of hypotonic saline is used to hydrate the flap and hence assist to iron out the folds. The direction of the movement of the sponge to iron out the striae should be perpendicular to the direction of the striae. The flap is placed back. Notice the vertical fold, but this will not be seen on the next day. On examination on the next day, the vertical fold disappears. Another case of a nasal hinge and a decentered inferior flap noticed after the first 24 hours, in which the epithelium...
So here we remove all the epithelium and you can see that the whole flap has got decentered and gone down. It's a nasal hinge. I have a Schwind microkeratome, so you can do a superior hinge or a nasal hinge.
Ironed with the use of hypotonic saline and 2 dry sponges. The hypotonic saline is used to hydrate the flap and iron out the folds with the same action of the 2 dry sponges. The flap is repositioned and these folds disappear the next day.
Now this is a case of epithelial ingrowth, which is very little. It's only on the periphery, so you can see that that's the area where the ingrowth is. So you just have to lift that area and clean it, then that's fine. So then there is nothing to worry. So you can see this is larger epithelial ingrowth. Here we will lift the flap, evert it, and then scrape the back.
The stromal bed is scraped off of all the epithelial cells possible.
Don't forget the back surface, and you will see this thing peeling off.
The back surface of the flap is then tackled off the ingrowth. The flap is gently held with the help of the sponge, and then the ingrowth is slowly, gently being peeled off.
And this does very well. As mentioned by Dr. Ramamurthy, you can use 20% alcohol, but normally first attempt I don't do anything and it goes quite well. And it just comes off. Once it is off, just place the flap back and you're fine. Now I'm going to go to another one case. This is, patient has come after a week, okay? And there are a lot of wrinkles right in the center.
After day 7.
So
a good iron out of the wrinkles, the epithelial...
So if there are wrinkles in the center, in the optical zone, in the pupillary area, after 7 days, there's no other option but to remove the epithelium. But you have to know the pre-op flap thickness. So if you have a flap thickness of 100 microns, you have 60 microns of epithelium, then what you're dealing with is only 40 microns. So you have to be very, very careful.
Essential on the central optical zone.
And these patients do extremely well. The principle is the same. Remove the epithelium on the optical area. Make sure the thin flap is lifted. Again, irrigate both sides 90 degrees to the wrinkle. And once that is done, place the flap back and epithelium comes back. And the patients do quite well. I'm going to show you one flap complication. This patient had RK and we had done LASIK on that. And once the LASIK was done on that, the patient came next day with a torn flap. Okay? So here you don't need to mark. The reason being here is that you can see that just remove the epithelium from the side. And you can see in a torn half flap, it's going through the pupillary area. You'll be surprised that I cleaned everything off, removed the epithelium, realigned, because the RK marks itself helps you, so you don't need to be confused on the right side, up or down side. It really doesn't matter. Just align the RK marks and that's going to be well. And you can see it's going through the central area. So done all this, aligned it, put it back, and once I put it back, All I did is irrigated it and then put a contact lens. I did not take sutures. Normally one may need to take sutures, but you'll be surprised. I kept the contact lens for 3 to 4 days and this completely disappeared and the patient was doing extremely well. I'll show you one last case. A decentered femto flap. This was the 4th case of my career. I started LASIK femto around, this was on the Z4, this was about 11 years back. And you can see a decentered femto flap, the hinge is in the pupillary area. So it's very important to understand the mistake I made. The mistake I know what I had made is the relation to the technology that you're using and how you're using it. So it's very important to understand that, but you don't need to worry. So I've actually cut the conjunctiva, the hinge is at the area of the pupil. What you do is go deeper. So if your initial cut was 100 microns, you make the second cut at 130 microns. Do exactly the same thing and then lift the area away from the area where it was originally there. So you can realize that I've started to lift. I made a femto flap and I've started lifting it from away from the area where the original cut was. And then you'll get your plane. Once you get that plane, go ahead and do your ablation and everything goes very, very well. So nothing to worry. If that happens, you can easily go around and take care of that. Thank you.
Presentation, you covered up almost all these complications and very nice